Throughout this webinar, we are going to review the Advanced Life Support Patient Care Standards version 5.4 for both PCPs and ACPs, and the expected changes that will come into play June 2nd, 2025. Throughout this presentation, we will highlight the addition of both PCP and ACP new core directives, updates to core directives, and new auxiliary directives. The current slide outlines the changes that apply to PCPs. You will note each change will be marked by the corresponding colored arrows you see to the right of the list. This slide outlines the changes that apply to ACPs. Again, each change will be marked by the corresponding colored arrows you see to the right of the list. The Advanced Airway and Tracheostomy Suctioning and Reinsertion Medical Directive is not new. What's new is the added skill within the existing core directive, which, as you will recall from 2024 MCME last year, is the option to suction down the gastric port. This addition will apply to both PCP and ACPs. Note the indications being the utilization of an SGA with a gastric suction port, where we have known or suspected gastric secretions or emesis following the placement of that SGA, or there is persistent difficult ventilation despite other efforts to improve ventilations. This is the same messaging as from your 2024 MCME. Under treatment, suctioning levels align with the ones we currently utilize in our trach suctioning directive. For each age parameter, start low and work your way up to the appropriate level. It is not advised to start at 100 millimeters of mercury for each group. There have been no changes to dosing, and the expectation is we are still suctioning until fluid disappears or after 15 seconds of no fluid return. A soft reminder to leave your suction tubing in situ and to simply be turning your suction machine on and off as needed. There are no changes here within the clinical considerations, and messaging remains the same for troubleshooting. When paramedics run into difficult ventilations, they should be considering reassessing SGA sizing, visualizing and auscultating for possible displacement or obstruction, checking if the VVM valves are functioning, and these are just a few examples and a long list of possibilities. This will occur prior to the decision of suctioning. Within the medical cardiac arrest directive, we will see some points added and removed for both PCPs and ACPs. First off, the specific list of primary clinical considerations has been removed. These all still apply, but are now housed in an all-encompassing statement under point number 2, known reversible cause of arrest unable to be addressed, giving paramedics more opportunity for clinical decision-making with those suspected reversible causes. Secondly, we will see CPR removed from conditions as it is already listed in the ALS PCS and was redundant to have it sitting in both. The expectation, however, is still to perform CPR in the setting of cardiac arrest. Added, you will note, is double sequential and vector change in the setting of refractory ventricular fibrillation or pulseless VTAC. Within the mandatory provincial patch points, you will see some wording updates for both PCPs and ACPs. First off, patch to consider medical TOR if applicable. Patch early to consider TOR if there are extenuating circumstances or where the paramedic considers ongoing resuscitation to be futile. And if the patch fails and/or there's been no ROSC after 20 minutes of resuscitation, initiate transport. Vector change defibrillation has been added in as a core directive for all paramedics, where double sequential external defibrillation has been added in as an auxiliary directive. Therefore, only those paramedics who have been certified and are working within a service that has adapted the directive may utilize it. Let's review the directive. Under conditions, you see the age of the patient must be 18 or greater. We are looking for non-traumatic VFib or pulseless VTAC of presumed cardiac origin, and 3 consecutive shocks must be delivered by paramedics or participating fire services prior to the switch to vector change defibrillations. It is important to note that for those services who partook in the original dose VF trial, where double sequential or vector change could only be considered when the presenting rhythm was VFib or pulsus VTach, this direction has now been removed. If at any point your patient has received 3 consecutive shocks by EMS or fire, they meet double sequential or vector change defibrillation, regardless of the presenting rhythm. There are no contraindications to double sequential or vector change defibrillation. Treatment outlines a vector change defibrillation occurring at 2-minute dosing intervals. This aligns with the AHA standards of cardiac resuscitation. Here we note some added details in the clinical considerations section of the medical cardiac arrest directive. To break it down, this says that if double sequential external defibrillation is used, which means it is authorized, that a paramedic service defibrillator is preferred over a fire service defibrillator. Also, that the fire service defibrillator can be used if agreed upon by the fire service. Finally, that if a double sequential is not available, that vector change defibrillation should be provided for refractory VFib or pulsus VTach. As a note, should the circumstance arise where the second responding unit has not been trained in double sequential, then at the time of transport, it will be the certified crew who will transport the patient. The traumatic hemorrhage medical directive has been added in as an auxiliary directive for both PCPs and ACPs. Therefore, paramedics will need to wait to hear from their service before utilizing this directive. We've seen some updated directions since our 2024 MCME last year. First, we see the removal of OR under indications for TXA administration. Our indications now are suspected hemorrhage due to trauma and hemodynamic instability, with the conditions being your patient is greater than or equal to 16 years of age, with a heart rate greater than or equal to 110 beats per minute, or hypotension. Contraindications are known hypersensitivity to TXA, greater than 3 hours from time of injury to drug administration, or unknown time of injury. The rationale for this time frame stems from the CRASH 2 trial that showed an increase of thrombolytic events were a possibility. And lastly, isolated head injury. The rationale for this being the CRASH 3 trial, which showed no benefit to patients in the setting of an isolated head injury. Under treatment, you will note 2 routes of administration: IV and intramuscular for both PCPs and ACPs. ACPs will note direction has changed and there is no longer an IO route of administration listed for this directive. Under clinical considerations, we are reminded that as with any major trauma situation, urgent transport should always be a priority over obtaining an IV or drug administration. Here, the medical directive explicitly reminds paramedics not to delay transport or treatment for TXA administration. Management of other reversible causes may include controlling hemorrhage, providing ventilations, and/or managing intention pneumo. If resources are available, treating these conditions can occur concurrently. Here we also see the expected duration of IV infusion of at least 5 minutes. This is a change from the messaging in your 2024 MCME, where it was presented as an infusion time of 10 minutes. With finalized edits to the medical directive, the time frame of 5 minutes was decided upon. Please note that an infusion over 10 minutes will be acceptable practice, as the direction reads at least 5 minutes. As a reminder, paramedics are to frequently reassess patients for hypotension. As we know, rapid infusion of TXA can pose that risk. Also to note, TXA should not be considered in the case of a traumatic arrest patient. The ALS PCS 5.4 sees the addition of an auxiliary tachydysrhythmia medical directive for PCPs with those patients requiring Valsalva for confirmed SVT. Prior to this ALS PCS update, SWARP has educated and authorized its PCPs in this treatment since 2018. It is important to note that the tachydysrhythmia directive houses 2 auxiliary directives within a single medical directive. They are independent of each other so it is especially important to understand which components of the directive the service you are working in is utilizing. The treatment component of the medical directive has not changed. Please remember to complete a 12-lead ECG and interpretation to confirm QRS width. There is the added notation that this can be completed if it won't delay therapy. But within the PCP scope, the recognized patient has to be hemodynamically stable, meaning unaltered and normotensive. Therefore, obtaining a 12-lead ECG should not be a barrier prior to performing the Valsalva maneuver. Here is the pictorial of the procedure. The patient will be in a seated position, preferably on your stretcher. Paramedics will provide the patient with a clean needle-free 10 cc syringe and instruct them to attempt to push the plunger of the syringe out the other end by forcibly blowing into it. This occurs for 15 seconds. At that 15-second mark, the patient is laid back, flat, and legs are lifted 45 degrees for another 15 seconds. Post that 15-second mark, the patient is returned to their upright seated position to see if a normal sinus rhythm was obtained. If conversion does not occur, another attempt is made when the patient is ready to do so, as long as the patient still fits within the specific parameters. This will require paramedics to obtain a new set of vitals and a 12-lead before another attempt. The allowance of the Valsalva maneuver is 2 attempts per patient, not per paramedic. The second component of the tachydysrhythmia medical directive is the treat and discharge component. This is new for PCPs. It has been an auxiliary medical directive for the ACP scope of practice since the introduction of the ALS PCS version 5.1. Again, it is important to check with your services as to what auxiliary medical directives are being utilized. Lateral patella reduction has also been added in as an auxiliary directive. There are no changes, and the same direction that was given in your 2024 MCME still applies. Indications remain the same. Conditions have received no changes, and contraindications remain the same. There have been no updates to treatment or clinical considerations. As a reminder, this is an auxiliary directive, so please take note to what your service is utilizing. There have been some updates within the Analgesia Medical Directive for ALS PCS 5.4 for both PCPs and ACPs. Let's review them. The first change that we see within this directive is normotension has been removed from conditions for ketorolac for both PCPs and ACPs. Additionally, for ACPs, normotension has been removed from conditions for fentanyl. Both of these medications have been proven to be safe for patients with soft systolic blood pressures. Under the ACP scope, the procedural sedation medical directive also contains fentanyl. The normotension condition is still listed here in the ALS PCS 5.4. However, this was an oversight in the update, and SWARP suggests using the same parameters of not applicable for systolic blood pressure in the procedural sedation medical directive. ACPs will see the addition of ketamine as a consideration for those patients requiring analgesia for pain. Treatment is broken down into 2 age categories and offers 2 routes of administration. For those aged greater than or equal to 1 year and less than 18 years of age, please see within the treatment chart the appropriate dosing for both IV and intranasal administration. Dosing interval is 15 minutes with a max number of 2 doses. For those greater than or equal to the age of 18 years, please see within the treatment chart the appropriate dosing for both IV and intranasal administration. Again, we see dosing interval as being 15 minutes with a max number of 2 doses. Soft reminder, there is a mandatory patch point for when we are considering ketamine in those patients less than 18 years of age. This will allow communication between the paramedic and the physician regarding specific dosing for this sensitive patient population. Please note that this is a higher age for the mandatory patch point required for fentanyl and morphine, which is 12 years. Clinical considerations houses some important wording reminding paramedics that the administration of morphine or fentanyl and ketamine must be sequential and not co-administered. This means that if a patient received fentanyl first, they can be administered ketamine at least 5 minutes after the fentanyl. This is the most recently administered medication dosing interval. A second example of this would be if a patient received ketamine first, they can have either morphine or fentanyl administered at least 15 minutes after the ketamine, as 15 minutes is the dosing interval of ketamine. Remember, the key to selecting analgesia for your patients is to know the benefits and the potential side effects of each. With ketamine, the benefit is that it is generally hemodynamically stable and may provide some mild disassociation in critical situations. The risks are potential hypersalivation, laryngospasm, and K-hole responses, where you'd see an unpleasant dissociation that can cause distress or combative behaviors. This is the medical director's messaging on choice of drug in analgesia. Lastly, we will take a look at the nausea and vomiting medical directive and the changes seen here. There is the possibility of misinterpretation, so we will take a focused look on those changes. Starting with dimenhydrinate, the age parameter of less than 65 has been removed and reads NA. We will discuss this further on the next slides. There have been no changes to contraindications for dimenhydrinate. The way this directive now reads is that dimenhydrinate may be administered to patients greater than or equal to 65 years of age. However, only if ondansetron is unavailable. The key here is that the definition of unavailable pertains to the procurement of the medication, meaning the service cannot supply ondansetron, not in the circumstance where paramedics have not been able to restock their trucks yet due to call volume. If ondansetron is unavailable, an initial reduced dose of 25 milligrams of dimenhydrinate can be administered to this patient population if the benefits outweigh the risks. Some risks of administering dimenhydrinate to elderly patients include sedation, precipitated delirium, and interactions with other anticholinergic sedating medications. These can all negatively impact the patient's ability to be properly assessed and diagnosed by yourself or hospital staff. The dosing of dimenhydrinate for patients under 65 years of age should be dependent on their weight as seen here. Another important take-home within this directive is that if ondansetron is available, but the paramedic believes a patient would benefit from dimenhydrinate and is greater than or equal to 65 years, you must first patch to the base hospital physician to obtain orders to administer this medication. With ondansetron, we see the updated additional routes of administration, depending on what your service carries. Paramedics may now consider PO, IV, or intramuscular where appropriate. You will note a wording change here in clinical considerations. You see the removal of ondansetron and dimenhydrinate was replaced with antiemetic. However, the messaging is still the same. Thank you for joining us. This concludes our ALS PCS version 5.4 updates. Should you have any questions or require further clarification regarding any of the new changes and updates, please feel free to reach out to us at SWARP, and we will do our best to provide clarification.